All right, we're so excited to be here on Doctors Unscripted with Dr. Robert Mileski with Phoenix Orthopedic Group. So, Dr. Mileski, first off, love to hear a little bit about your background. What got you into medicine, and why did you decide you wanted to become a doctor?
Thanks for having me. I grew up in a suburb of Chicago. I originally come from a medical family, but I guess my parents recognized that I had some interest in medicine. Whenever they had to go to the doctor, I must have been somewhat intrigued or eager to go, or curious about the process. So they encouraged me, and I think they encouraged me because it's kind of viewed as being a good job.
Yeah,
and
for sure.
and so I ran with it.
Okay.
Yeah.
So, your background is orthopedic surgery residency, and then you did a sports medicine fellowship, correct?
That's correct.
Okay, so the intersection of really that sports medicine and orthopedic surgery, I think, is really, really interesting. So, what type of patients normally come in to see you, really for your specific expertise?
Well, again, orthopedics, as most people probably know, is typically muscle and joint types of pains, and so since my practice is, I see all sorts of different conditions, but I have a focus on shoulder and knee conditions. So, shoulder pain, I twisted my knee, I can't reach up overhead, I ripped something, throwing things out in the garbage, and those would be sort of like I was putting something in the overhead bin in the airplane, and all of a sudden my shoulder started hurting. So those would be the kinds of things.
So, talk to me a little bit about how a sports medicine fellowship kind of changed your view on orthopedic surgery. Did it add, did it augment? Like, where do those intersect?
Can I redirect here just for a second?
Absolutely.
Because I don't know if you asked this at the very, very first question in terms of how I got interested in medicine in general.
Absolutely. Yeah.
But I wanted to just sort of mention about how I then got interested in orthopedics.
Oh, that'd be great. Let's hear that.
Yeah. So in this instance, and my mother, when she was young, this is actually a pretty good story, but in any event, we were from Chicago. The last name is Polish. She grew up in the Polish neighborhood when she was young, and she was born with congenital dysplasia of the hip. And so in that situation, the hips don't form very well for whatever developmental problems. And so way back then, the treatment was frequently traction. So she went into Phoenix Children's Hospital. We don't do this way these days, but she was in some form of traction for up to 4 months, and it was just, and that helped her, but it didn't obviously ultimately cure her. So the two parts of the story is, one, she went into the hospital speaking Polish and came out of the hospital speaking English. Was one of her stories. But as it relates to my pursuit of orthopedics, she still had a lot of disabling pain, and even at age 52, would just have disabling hip pain. And so I was able to witness that she ultimately had hip replacement. Changed her life dramatically. Was able to join the golf league. Was able to dance with my dad and those types of things.
Yeah, I know that's something that we hear about a lot, is that hip replacement surgery, if they're a good candidate, can just be life-changing with some of the relief. That it looks like a very complex, pretty invasive procedure, but I've heard the results are just fantastic for that.
Well, the results are spectacular, I have to admit, which I've evolved into, so now I like the shoulder and the knee even a little bit more, so it was somewhat disappointing to me when I stopped doing hip replacements, because admittedly the patients do spectacular. And particularly with now, the anterior approach to the hip, a lot of the hip replacement doctors do, and it seems like I've seen really, really quick recoveries.
Absolutely. So, that's kind of how you got into orthopedic surgery. Why did you decide to go into now a sports medicine fellowship after orthopedic surgery? So
for me, for sports medicine, it somewhat relates to the type of conditions that you treat. Most doctors that are sports medicine guys are particularly well, they had somewhat of an athletic background, so they participated in sports, and they saw the types of injuries that individuals got, so they had some familiarity with them. So that would be one reason. And another reason would be the types of procedures that you do are kind of pretty fascinating. And
Yeah, absolutely.
for me in particular, although I do all sorts of conditions, relating to the knee and the shoulder, at the time of the end of my residency, arthroscopic rotator cuff repair was getting, in its evolution. So like ACL reconstructions that had already been performed quite a bit, and but now it's arthroscopic rotator cuff repair was taking hold. And I don't know, to me that was just sort of, it's kind of fascinating, because the way you repair a rotator cuff in an open manner versus the way you repair it arthroscopically are
very different.
Pretty substantially different. So I was a little bit intrigued, like, can this work? And so,
how's that been? So let's talk about that a little bit. So, if you're trying to repair a rotator cuff or anything like that, I know we get so many patients that come in with shoulder pain, rotator cuff injuries, partial tears, full tears. How has that evolution from an open technique to the more minimally invasive process gone as it pertains to the shoulder? Are we seeing better outcomes? What's the recovery look like? What does that overall the procedure shift look like?
So even when I trained, and I trained with an individual whose name was Steve Snyder, and he was one of the frontier guys in terms of the evolution of the project. But even at that time, we were maybe doing 50% of the cuffs arthroscopic, 50% open. And now I'll bet practically every 95% rotator cuffs are being performed arthroscopically. And I think a lot of that had to deal with innovations in technique. A lot of it's tools, like how do we pass sutures through tendons, and so those things made it a little bit easier. I don't know that I can say for sure outcomes have changed dramatically, but I do think that the degree of pain associated with the procedure is probably less with a more minimally invasive.
I mean, that makes
procedure.
sense. Less cutting, and again, rehab should be faster as well, because less cutting through tissue and stuff like that, you should heal a little bit faster.
I don't like to be misleading, because to a certain extent, yes, in terms of less tissue involvement, less, if you don't have to make an incision and split the deltoid muscle, there may be a little bit less recuperation. But I always tell people, I can lay the tendon, or we can lay the tendon down to bone, but it still takes natural biology.
There's still limitations on the body to heal.
Let that tendon actually, because the tendon physically ultimately grows back into the bone. Which is pretty fascinating.
It is fascinating.
The body can do that.
So I know a lot of people interested, obviously, in surgery that have shoulder pain and knee pain, but they also have a high interest of not getting surgery. And we see when patients come in to us, one of the things they say is, there anything I can do to avoid surgery? And there are obviously cases that they just need surgery, but there are things that can be done sometimes in certain cases that are good steps before surgery. So what I'd love to do is talk about what are some of the alternatives to surgery that can be done that have a moderate to good success rate that people may or may not be aware of.
So a lot of that, I think, depends on the specific condition, the duration of patients' ailments, the degree of debility. All those things will be factors into how you structure your treatment plan. But of course, we're always going to try the least invasive and the most conservative treatment options first. And for me, that frequently involves use of anti-inflammatory medications.
Okay, so let's talk about the shoulder then. So I have a shoulder injury, you've assessed it. One of the first things you may do is anti-inflammatory injections.
Well, oral anti-inflammatory medications and physician-directed home therapy exercises.
Okay.
So we instruct you on certain exercises to do, and sometimes formal physical therapy as well.
Okay. So let's say that we've tried those things, maybe done a steroid shot, oral anti-inflammatories, maybe, Toradol or some other NSAID injection. Like, we've tried some of the anti-inflammatories, still having some pain. Where do you go from there?
Well, if some pain means they're already getting better, then you probably stay the course.
Yeah.
If that's not enough pain relief, then my next move after oral anti-inflammatories, home therapy, formal physical therapy, might be a cortisone shot.
Okay. So that's when you may escalate to a steroid.
Correct.
Okay. And so let's say we do the steroid, still having shoulder pain. Where would you go next?
So I'd probably get an MRI at that point. Get a little more information, a little bit of a blueprint to see exactly, what the
Mechanics, what's going on, what's in there. Okay.
Now, mind you, I think very frequently, I always tell patients, I'm not the human MRI, but also very frequently through your history, physical,
orthopedic tests,
you experience, you got a pretty good guess of what the MRI may or may not show. But yeah, MRI would be the next thing.
Yeah, there's a phrase that I really like that says, seeing is knowing, not seeing is guessing. We don't want to guess with people's health, so we like to take imaging. And that's kind of a standard through healthcare. We have a good idea of what's going on, but it's still, there's that unknown small percentage point that when we see it, it takes that confirmation and we can now go, okay, let's proceed. So you take the MRI, you now feel super confident. Even though you may have been 99% of the way you knew what was going on, you now say, I've got the imaging, and that's when you may recommend some type of surgery depending on what's seen. Is that correct?
Correct. So in the shoulder, see, it's hard for me to answer the question directly because I'm thinking, okay, is this hypothetical patient have frozen shoulder?
Yeah.
Do they have a rotator cuff tear? Do they have a full thickness rotator cuff tear? Or do they have a low grade partial thickness rotator cuff tear? So it is somewhat dependent on
the actual diagnosis, for sure.
Stuff. Now, having said that, I guess and there's different reasons based on different conditions that I may or may not be getting an MRI.
Yeah.
So rotator cuff, I'm very aggressive about, or not very aggressive. I like the MRI a lot. It provides a lot of useful information.
Absolutely.
Because sometimes, is it a rotator cuff tear? Is it a partial tear? Is it a high-grade tear? Is it a full thickness tear? How retracted is it?
Absolutely.
How much fatty atrophy is it? So there's how big is the tear? So those are factors that then affect the next thought.
Absolutely. So, as we're looking at different types of injuries, obviously you want a doctor who's going to tailor treatment to the condition, right? It's not a one-size-fits-all, and I think sometimes surgeons do get a bad rap for that, which is they're going to say, well, you go to a surgeon, they're going to recommend surgery. If you're a hammer, everything looks like a nail. And we hear that so often. I've said it on the podcast multiple times. This is something that surgeons oftentimes get a bad rap on. But, good surgeons are going to say, make sure that the treatment fits the condition. And yes, if there is a, full tear on a rotator cuff, guess what? You need surgery, right? You're going to get surgery.
But I couldn't agree with you more in terms of what you've said. So it's. I have to sometimes tell my patients, just go, if that's not something that I don't do surgically. Radicular pain, shooting pain down the leg. Well, go see the provider. It's a consultation. It doesn't necessarily mean that you're going to have surgery. You want to have that relationship with the provider to see if they can help you and what the next move might be.
Yeah, sometimes developing a relationship with a surgeon early on can be really helpful because you may not need surgery, but having that relationship through different types of modalities, whether it's the injections, whether it's the physical therapy and stuff like that, it's going to help you to progress to where if you do need it, you already have that relationship and you can go that route, and they've seen you through that care. So that does make sense. One thing I want to talk about, though, is we get asked a lot about regenerative modalities, right? Mm-hmm. So such as, PRP or even platelet poor plasma, PPP. So PRP, as far as the different types of conditions, generally speaking, I know you do PRP. What types of conditions do you feel like do the best with PRP?
So for me, the best is probably the low-grade partial rotator cuff tear, particularly if there was somewhat of an acute onset.
Yeah, that makes sense.
Because it just kind of makes sense. You're asking a tendon to heal.
Yep.
So a full thickness rotator cuff tear, that tendon's not going to jump all the way to the bone with a biologic agent.
Absolutely.
But an intermediate grade or low grade partial rotator cuff tear, maybe that's got a good chance.
Yeah. Mm-hmm. And again, like if a patient's hesitant to do surgery, it's like we can always try it. And if it doesn't resolve, you still have the option of surgery, right?
And you haven't burned any bridges.
Yep. And so I do love that as an option. So let's talk about PRP for just a moment. For our audience that may not know what that is, can you explain what is PRP and why do we like it as a modality?
PRP stands for platelet-rich plasma, and so platelets have, you may know more about this than me, but in any event, platelets have platelet-derived growth factors. So there's all these different types of growth factors that platelets have, and obviously they're intended to try to help the healing process or modify inflammation, those types of things, and interleukin-1s and fibrinogen growth factor 3, different types of things that. So you draw blood, you spin it in a centrifuge. The red blood cell layer gets discarded, and then the platelet layer is a very, very thin layer just above the gel of and it gets mixed in with the plasma, and so now you have platelet-rich plasma,
which is just concentrated platelets.
It's concentrated platelets. So you want a lot of platelets, more growth factors, more chance for healing.
Yep, so one of the things that I like to describe this when patients ask me about this is your body naturally knows how to heal, right? Like when you get a cut, your body knows exactly what it's supposed to do to heal that. It doesn't heal because we take aspirin or ibuprofen. Like, it heals because our body knows how to heal. However, there are times where our body may have difficulty getting all of the healing agents from the blood to that area, such as in a joint capsule where, we may have indirect blood flow. Right, and so by getting those direct healing and growth factors to the area of injury, you can actually accelerate some of that healing process. But it's not really the PRP that's healing your body. Your body's healing your body. You're just getting the building blocks to the site of injury so the body can actually make those changes and repair, right?
Absolutely.
And so PRP, awesome modality. We've seen really good results also with arthritis. Have you done PRP with arthritis at all?
Yes. I'm not saying that it doesn't work, but it maybe seems to work a little bit better in tendinopathies than arthritis. But for me, from my experience, the arthritis response has been kind of variable. I've had some patients that didn't feel it helped at all, and I have many that have been very, very gratified.
Yeah, and again, I think with any type of care that's out there, there's definitely the question of it is going to work for some, and it's not going to work for others. And so it's really trying to match care to condition, and then giving patients, the option of, hey, these are the pros of this, and here's the cons, and here's the pros of this modality, and here's the cons, and what do you feel is best for your situation, and letting them decide what's best for that. And absolutely, I think creating the right expectations is 100% going to be involved with whether a patient has a good outcome. If you say this is 100% going to work and it works 99%, they're going to be upset.
Yeah.
But if you say, hey, you know what, we've got a decent chance of this working, but it might not work, and then it does work, they're happy. And if it doesn't, they say, I guess this wasn't right for me, and they go on to the next modality. So really important to set good patient expectations. So let's go on. So PRP can be used for, obviously, different types of tendinopathies and stuff like that. And then also there's moderate evidence that it can be helpful for arthritis, depending on obviously the stage and condition and everything like that. What about platelet poor plasma? Have you done anything with platelet poor plasma?
No, I haven't. I mean, I use platelet-rich plasma, but there's leukocyte-rich and leukocyte-poor. So for the leukocyte-poor version, that's where I would use that in an arthritis situation a little bit more.
Yeah, I know there's a growing body of evidence of stating that PPP, platelet poor plasma, can be really good for muscle healing as well, which is interesting. And so they break that up into saying PRP can do really well with, tendons and cartilages. That's what we're dealing with arthritis and stuff like that. Whereas platelet poor plasma can be better for more of that high vascular tissue and stuff like that to help with healing. So again, it's really, I think it's fascinating as we see research growing and as we see different types of modalities coming about. I mean, PRP's been around forever, but people still come to us with questions, say, hey, does this work? Is this the right modality? And, obviously you try to be evidence-based, but there are things that maybe don't have the body of evidence that maybe a drug or a surgery has, but have been anecdotally very effective. And so when patients ask about PRP and whether it's going to work, what type of expectations do you set around PRP?
So a couple of things. and there may be more studies that I'm completely aware of at this moment, but there are, having had reviewed this in the past, certain conditions we have legitimate, good, patient-controlled studies that have supported the definite benefit in PRP, and those are for like tennis elbow or lateral epicondylitis or medial epicondylitis or hamstring strains and injuries. Although there have been studies that have supported that very well. Some of the other studies may not be as good, but that doesn't mean that it may not still be valuable. And so that's what I try to share with my patients. We don't have really good studies here, but this may be my experience with trying to,
and may still be a good
follow
option.
patients.
Yeah, absolutely. So, are there any other biologics or other types of natural modalities that you like to use for knee and shoulder injuries?
So in addition to PRP, on occasion I've used what's called alpha-2 macroglobulin, and that is a version of PRP, but it still maintains a protein in the blood.
Oh, interesting.
Some people feel that it may provide a longer duration of benefit, or maybe even be a little bit more successful. There are alternative PRPs that I haven't really utilized that much, that because they're less. They don't fall under FDA regulations, and some of those include things like Wharton's jelly. But also doesn't mean that I haven't heard some patients having good response from them when they were administered by someone else.
Yeah, so can we talk a little bit more about the, I think you said alpha-2 macroglobulin?
Yeah,
is that
but
right?
my experience isn't great with it. I've just probably about 10 or 15 patients.
What is that exactly?
It's a similar process in terms of the PRP, in terms of drawing blood. Sometimes you usually draw more blood.
Yeah.
And quite frankly, the centrifugation process, I guess, is a little bit different, and then it maintains a protein, and I think the protein that is maintained in the ultimate plasma is also deemed to be beneficial to the healing process.
That's fascinating. Very cool. I don't know much about that one. So, one other thing that I think that's important to mention with PRP is risk factors, right? Anytime that we are doing whether it's surgery, whether it's an injection, whether it's even physical therapy or chiropractic, regardless, there are certain risk factors with any type of therapy we're going to do. One of the things that I've heard from patients that they really like about PRP versus cortisone or other things like that is that it's from their own blood, right? We're not taking a foreign substance and injecting it into the body, but we're actually taking your blood from the patient, spinning that down and putting it back in. What has your experience been with have you seen that there's high risk factors with this, or do you feel like it's relatively benign because it comes from the patient?
Yeah, absolutely. I think it's very, very safe because it's on site. You take it out, you give it right back.
Right.
Just after a little bit of processing.
And that's what we've actually heard from a lot of patients is they really enjoy that part of it, knowing that it's very safe. And guess what? If it doesn't work, at least they tried something that was more natural and it was safe, and it's a good step along the pathway. And if you get wonderful results and you're happy and you can play pickleball again and you're doing great, all the better. And if you can't, at least you tried one of those modalities that has a decent chance of success with a pretty low risk factor. And I think in medicine, that's one of the things that we usually look for. High degree of success, low risk factors are ones that we really like to lean towards, because it comes to that process of, well, why not try it when it's, again, decent success rate, low risk. So with other surgeries that you've done, let's kind of move down to the knees. We talked a lot about shoulders.
Sure.
I think shoulders are fascinating. Knees, we have a lot of patients come in with different knee conditions. So what are some of the different knee conditions you feel like are common here in Arizona?
Well, obviously, probably two most would be meniscus tears and arthritis.
Yeah. All right, so meniscus tears, let's just break that down for a moment. So meniscus is kind of like the padding between the two bones, and a meniscal tear is going to be that cartilage tears, and usually it's in some type of sports-related injury. Is that correct?
Not always, you know. I mean, I tore my meniscus at age 38 just from getting up from a chair.
Just getting up from a chair?
Yeah.
Okay, so what happens biomechanically to cause a meniscal tear?
Well, most meniscus tears, I mean, I just illustrated an example that doesn't follow this, but are twisting injuries.
Yeah.
So you have two O-rings, I call them like the O-rings, and it's a meniscus. They're C-shaped, and it lives between the thigh bone and the leg bone. And sometimes when you twist, that'll put shear forces on the meniscus, so it'll physically tear.
And why is the meniscus important? Like, it's not really a padding, like I said, but it is. It looks like it when you look at the diagram of a knee. But what does the meniscus actually do to help the knee?
No, well, I agree that it's a padding. It distributes the load over a greater surface area, so there's less point pressure, in which case there's less likelihood that the other type of cartilage in the knee, the cartilage that overlies the bones, less likely that wears out.
Yeah, so really important to have that then, because that's, if we lose meniscus, most likely going to see an increase then in arthritis, right?
Correct.
And so, those two.
But not as rapidly as many patients would think.
Explain that.
So in the old days, before we had arthroscopy, if an individual tore their cartilage, the surgeons would make an incision and they would cut out the whole meniscus. Invariably, those patients, but it took 15 years, would develop bone-on-bone arthritis.
Interesting.
So now, obviously, for 50 years, you would do it with arthroscopic assistance, and so you trim up just the part of the meniscus that I tell my patients windshield wipers. So the meniscus got a tear in the C, and so you cut out the part that can move around, because the part that moves around can cause pain. So since you're cutting out less, that risk of developing arthritis also, it's not like we never see it, but becomes much, much less.
So I'm going to use a little bit of a different analogy. So it's kind of like if you have a hangnail, you're going to go in and you're not going to trim the whole nail. You're going to go right to that part that's hanging off, trim it so it's no longer catching and painful and everything like that. Is that accurate?
Absolutely.
Okay. So with meniscal tears, rotatory injuries in the knee are going to be the primary causation of those types of injuries. And when we do that, usually pretty minimally invasive, you're going in and just trimming off that meniscus so it no longer is snagging, catching, and painful. Is that accurate?
Correct.
Okay.
Try to preserve as much meniscus as you can.
You want to keep as much as you can. So from there, you also said another common injury that we have here in Arizona is arthritis.
Right.
Okay. So what causes arthritis?
So, well, I mean, in general, there's osteoarthritis, which is wear and tear arthritis, and then there's inflammatory arthritis, which is more like conditions such as like rheumatoid arthritis and those types of things. So in the former, it's wear and tear. It's, twisting, injury. Not everybody that develops arthritis has an injury, but the cartilage, for whatever reason, just wears out, and so that becomes bone-on-bone situation.
Absolutely.
And in inflammatory arthritis, there may be more, I'm not a rheumatologist, but there may be more inflammatory conditions in the synovium that can also degrade the cartilage.
Absolutely. So let's talk about osteoarthritis, because that's the main one that you see. When we're looking at osteoarthritis, you can have a 75-year-old patient who has no arthritis in their knees, and you can have a 75-year-old patient that has severe bone-on-bone arthritis in their knees, right? Why? Because obviously it's very common as we get older to have arthritis because we've lived a life of wear and tear. But how come some people can maintain really healthy, whether it's disc space in the spine or joint space in any of the joints, through age, and others don't do as well?
Well, some of it might be bad luck, but obviously things that are beneficial that you have control over is a healthy body habitus, and trying to not be overweight.
Yep.
And then obviously muscular conditioning, because if the muscles across the, if the muscles are strong, the force that the joint sees is more absorbed by the muscle, in which case then it's less likely that the patient will develop arthritis, or if they have some arthritis, will be symptomatic.
I love that. Yeah, so like a couple of factors for people that are wanting to avoid arthritis as they're aging. Obviously, good nutrition, eating well, staying healthy, low BMI, and I shouldn't say low BMI because BMI can be so subjective with working out and stuff like that. You can have a high BMI and have a low body fat percentage. So let's call it more overweight, right? So overweight, avoiding that, having good nutrition, and I love what you said as far as exercise and the importance of exercise. If you're exercising well and doing proper stretching and all of the things that go along with that, distributing force more evenly through your joints, as well as absorbing some of the shock. Instead of the joints taking it, the actual muscles take that. And so one of the most important things that I would say is how important it is to take care of your body as you grow, because by the time that you're older, it's too late then to do some of those things. Once it's degenerated, it's hard to regenerate. PRP is probably the best option we have of some regeneration, but even then it's extremely difficult. So take care of your body while you can.
Absolutely. Yeah. And I've experienced it personally, even after I had my knee scope, I was doing okay, and I just, I was like, my leg just feels kind of fatigued and weak, and surprisingly, when I upped my activity about 4 weeks out after surgery, 5 weeks out after surgery, I finally started feeling better. And I think it was the deconditioning the muscles and get the muscles back on and stuff like that.
Which is almost paradoxical in some ways, because we're talking about wear and tear on the joint is what causes arthritis.
Right.
But then again, exercise and movement makes the joint more healthy as well. And so again, I think it's the type of activity, like high shock into the knees, obviously, and stuff like that is going to wear and tear more than just walking and getting out and moving and doing those types of activities. So for people that have, let's say, moderate to severe arthritis, how does it normally manifest first as a symptom?
A pain with activity.
So, if they're sitting, don't really have pain, start moving, starts to hurt.
Mm-hmm.
Okay. So pain with activity.
And it may also be incited upon something. So once in a while I'll see the patient that, I don't know, minor fall to their knee or bumped it on the countertop or something like that. And now my knee's killing me. And then, well, it's because your arthritis. And then they'll be like, well, that just didn't cause my arthritis, but there was some type of a trigger that basically made the pre-existing arthritis become more symptomatic.
So 2 ways to really help people to understand whether they have it or not. Abnormal pain response in a joint with some type of activity, whether that's bumping it or moving it, or a small fall, and it's abnormally large pain response, more so than you'd think from the injury. And then the second part is pain on activity. What about stiffness?
Many patients that have arthritis will sometimes just say that they don't really have a whole lot of pain, but it's just real stiff.
Stiff.
Yeah.
Changes in temperature?
Sometimes.
Is that an old wives' tale, or is it real, to where if it gets colder they can feel it? They say, I feel it in my bones, which is, feel it in the joints. Is that real or not?
I don't know. I know, see so many people that I've heard this. I moved to Arizona, when our family came out to Luke Air Force Base because my doctor told me I had to go to a different climate and stuff like that. And I don't know. I don't know if that's a wives' tale or it's not a wives' tale. I'm not convinced that. I love Arizona. I'm not convinced that it makes
their joints feel better. Yeah. That's a good point, and that's an area of research I haven't really read into, but it's kind of interesting. So stiffness, aching, large amounts of pain after some type of activity.
Sometimes swelling.
Swelling. Okay.
Mm-hmm.
So if anybody's feeling any of these symptoms, what's one of the best things to do as a first step? So, they've been doing fine, they've been active, they fall and bump their knee like you just said, have an abnormally high pain response. They say, now my knee's killing me, stiffness, any of the stuff we just talked about. What's one of the best next steps for a patient that's feeling this?
Well, obviously, see the doctor.
What kind of doctor?
Well, you can see your primary care doctor, obviously, first, and they may initiate some of the conservative modalities that we talked about, but you can choose to see the orthopedic surgeon as well.
Yeah. I think that's one of the big questions that patients have. We have such a fragmented healthcare system. They have an injury and they're like, well, do I go to my primary care? Do I go to a pain doctor? Do I go to do I go to an orthopedic surgeon? Like, where do I go and where do I start? And I think the answer is just start.
Right.
It's like, if you go to the orthopedic surgeon first, they may send you back to a pain doctor or your primary care, depending on what's going on. But the more important thing is don't ignore the pain and see if it goes away. Like, if you have a condition, get it assessed by a doctor, understand the prognosis, and then at least know where to go from there, right?
I agree. I mean, again, 100% agree. you don't have to go in a week, but if you've tried a few things, some
Yeah.
activity modifications,
Ice.
I don't want to ice. A lot of the primary care doctors don't really aren't fond of anti-inflammatory medications because there can be some bumps in your blood pressure and stuff like that. My experience seeing the other side, I'm not managing their blood pressure, I'm managing their knee pain and their shoulder pain and whatever, back pain, is they frequently work and they're not a narcotic.
Yeah.
And so we
It's a
don't
better
want people
option.
on long-term anti-inflammatories, but a short-term anti-inflammatory to see if they resolve the issue that you already got going on is not an unreasonable idea. It doesn't, but right.
Yeah, I mean,
Get
like,
it sooner rather than later, ultimately.
it's you mentioned the competing priorities of different specialties.
Yes.
Right? I think it's a fascinating topic because, where in pain or in orthopedic surgery, it's going to be, we need some, let's say, an anti-inflammatory. But whoever's, monitoring their kidneys or their blood pressure might be like, oh, we can't be on anti-inflammatory,
Yeah.
right? So competing priorities. You see this with steroid and some of the different, immune conditions and other things like that. And so we see this in blood thinners and surgery. Like, hey, we need to come off blood thinners so we can do surgery. And it's like cardiologist is like, we can't go off blood thinners. And so
Right.
there's commonly this competing priorities between different specialties. How do you explain that when a patient's coming in saying, hey, my other doctor said I need to do X, Y, Z, and you're recommending ABC? How do you approach that?
Well, I guess a couple ways. Number one is recognize what the potential downside might be. So if the patient's told me I can take ibuprofen, I've never had a problem with it. I take Advil all the time. I've never had a problem with my stomach or anything like that. Do you have any problems with your kidney? Do you have any kidney disease? That may be a reasonable thing to do. Well, yeah, no, those medicines tend to upset my stomach, and we'd rather have knee pain than a bleeding ulcer.
Absolutely.
And that, which also then might make me lean a little bit more towards some form of an injection, because then
Non-oral,
they don't have
yep.
to. It's a locally administered anti-inflammatory, which shouldn't have the same toxicity profile or side effect profile, so that it's less likely that they have to take an anti-inflammatory. If it's deemed, in that case, that's not a great idea.
Yeah, absolutely. I think that the other part of that is really it's an unfortunate complexity of healthcare in the fact that we have to triage conditions, right? If you have really bad knee pain, but you also have a really bad clotting condition and we're worried about a heart attack or a stroke or anything like that, you may have to do other things for the knee pain rather than get the knee surgery if there's such a blood issue that we're concerned about that to the degree that you can't get surgery, right? And so I know that can lead to a lot of frustration with patients is, I have this, but this other condition won't allow me to treat my condition that's bothering me a lot right now, because obviously if you have a clotting issue or if you're at risk of, let's say, some type of cardiovascular disease or a heart attack, you may not feel that as much as your knee.
Right.
And so the knee's bothering you more, but one of them is more life-threatening than the other, and we have to really recommend care based off of preserving life above anything else.
Well, and that's where, even though we're talking on a topic that says there may be competing priorities, ultimately there's still outstanding collaboration amongst the providers.
Absolutely.
And so, hey, this is what I want to do, and this is what I think I need to do. Is that okay? Is it safe? Is it not safe? What's the other alternative? There's the dialogue that might go back to the cardiologist or the primary care doctor or the
that's
hematologist if they're managing the patient's blood thinner.
I think that's the area where we see the best collaboration between doctors is actually in these areas, because I do believe we live in a fragmented system, and if somebody goes to their primary care and then goes to a pain doctor or goes to a chiropractor or goes to an orthopedic surgeon, whoever they go to, right, oftentimes that provider only has the notes from what's been sent over, and they've never talked to the other doctor. They don't have a chance to say, like, they're starting almost from zero every time they see a patient. But in these areas where there has to be competing priorities, that's where I believe we actually do a much better job in healthcare of collaborating. Hey, we need to do this surgery, cardiovascular. like talking to the cardiovascular specialist, whatever they are, cardiologist or other, and being able to say, hey, we need to have them come off this blood thinner. Can we, do some type of, Lovenox bridge or something else to be able to get the patient the care that they need. And so I do believe that for patients out there that have this concern, there's actually an amazing amount of collaboration at the specialist level and at the especially at the surgical level with the community of providers that are treating a patient. Whereas more at the beginning of care, this is primary care, physical therapy, chiropractic, pain med management, there's a lot less collaboration than there is at the surgical level. So I actually believe you're right that there's much better collaboration there. So I have a question. So we deal, obviously, in our company, we deal a lot with the opioid epidemic, and it's something that's very close to our hearts. We are striving to say, how can we defeat the opioid epidemic? And every guest that we have come on, I always like to ask their opinion on ideas on how they believe that we can help solve that. So the question is, what are some thoughts or ideas that you believe that we as a healthcare community can do to help solve the opioid epidemic?
Two things. For me, one is a little bit more use of injections.
Yeah.
So that you don't have to have, so pain pills. The other is, I've always been surprised how often, if a patient says to me, well, I want hydrocodone, oxycodone, and don't get me wrong, post-operative pain is painful,
Yep.
and so it's completely reasonable to take those medications, and we prescribe them. For alternative circumstances, maybe less, maybe more non-surgical pain, or pain after further along in the healing process, after, let's say, a surgery, one would expect, well, you shouldn't need narcotic analgesics any longer.
Yep.
It's surprising to me how often I tell patients, well, one of the reasons we don't want to do this is because we don't want you to become addicted to these drugs. And I was always surprised that they're like, oh, really? Okay. And so just that bit of education frequently will help.
Yeah. Well, and I think that's such a great point, is there is a place for opioid-based medication, right? Post-surgical, they can be fantastic for helping. And even in some conditions, they can be really, really helpful. But the fact is, and I know we believe this at Arizona Pain and at Pain Doctor, very specifically, we do a lot more injections rather than medications as a first defense on that. And again, it's for that reason that you just said, is we want to do everything we can to try to help you with your pain, but not make you be reliant on a substance that is highly addictive. And yes, it can be good at treating pain, but the truth is that the longer you're on them, the less effective they are and the higher dose you need. And so there's this thing that says, well, is it addiction of why they're taking higher and higher doses, like that they feel like they need it, or is it becomes they're less and less effective, and so they need more and more and more? And yes, they are addictive, but there's also this whole factor of they're in pain, and if you can treat the underlying pain, that's one of the best things you can do to decrease reliance on opioid-based medications. Is if you can get rid of the root cause, you can get rid of at least the pain part of the reliance. You still may have the addiction, but you're not going to have the part of saying, if I don't take this, I'll be in immense pain and I can't live my life. So I love that, of education paired with treating the root cause, which is what I take injections to be, and keeping them reserved for when they're absolutely necessary, right?
Absolutely.
So anything else to add on that topic?
I don't know the answer to this, but it also seems not very likely that, and I could be wrong, all right, that physicians' prescriptions of opioids is what fueled an opioid epidemic.
Yeah.
I don't know.
Yeah, I mean, I know if we look at the research on that,
Well, maybe some of the OxyContin stuff, maybe yes, I don't know.
Yeah, it's definitely interesting. A lot of patients that, I think the research is somewhere around 70 to 80% of patients that end up dying from opioids started on a pain prescription, but that's not what killed them, right? They got addicted, and then they moved to more street drugs, and then from there they escalated, and from there that's what actually caused, death. And right, so we have over 100,000 people dying from opioid-related issues. That's not all doctors writing scripts, right? And I think that's important to recognize, is where opioids do have a place in the treatment of patients. They do need to be limited, and we do need to work on how we can better treat the source. We need to do better at educating. But at the same time, there's a lot of other things, to your point, that are contributing to those numbers that are outside of the doctor-patient relationship. And I think that's a really good point.
Well, that's insightful, and obviously it's indicative of your concern regarding the issue.
Yeah, and so again, we'd like to talk about that. We'd love to work with great doctors like yourself that are, similar in their philosophy of saying, there's other things that we can do to treat that, like you just said, education, injections, and so that's fantastic that you're doing those. So as far as kind of rounding out the interview, one of the things that we like to ask is really, in order for patients to get to know you a little bit better, there's a question that I like to ask a lot of our people that come on. And it's, if being a doctor wasn't on the table, couldn't be a doctor, what other profession or calling do you feel like you would have pursued?
Wow. It's great that your audience knows that this is unscripted. So, you know what I mean? It's a good title. How honest. I mean, I landed where I belong. I can tell you that, and that's really grateful. I'm happy about that. I guess the when I was young, when you're in high school, I don't know. I think they may administer a test that asks all kind of like silly questions that somehow the answer to those questions can paint you in a direction as to what you're most suited for. And I know for me, the three, and I don't think medicine was one. I think medicine was two, but it was engineering, architect, and medicine. So there was something about my personality type that directed me in those directions. And so maybe one of those. Then there's always the concept of being a businessman and a successful businessman. That'd be appealing.
I think that's fascinating what you just said, because an architect, an engineer, and a medicine is what I'd say describes an orthopedic surgeon, right? Because what you're doing is you're thinking about the biomechanics and the engineering.
That's true.
The architecture is really that design and everything, and the medicine. So I think you're absolutely right when you say you landed where you were supposed to.
It's a nice conversation. I never thought of that.
I think that all of those came together for you to be an orthopedic surgeon. So that's pretty awesome.
There you go.
Okay. Well, thank you so much for coming on today on Doctors Unscripted. We love having great doctors on, and obviously we send you patients because you're very good at what you do, but we're grateful to have the relationship, and thanks for coming on.
It was a pleasure. Thank you.
Absolutely.